We'd like to welcome Dr. Usman for his grand rounds on the evolution of dual antiplatelet therapy after coronary stent implantation. Dr. Baber received his medical degree at the University of Texas Southwestern Medical Center in Dallas, where he also completed residency in internal medicine. He moved to New York City, where he completed fellowships in clinical cardiology and coronary vascular intervention at the Mount Sinai Medical Center. He also earned a master's degree in biostatistics from the Milman School of Public Health at Columbia University. Dr. Baber is now an assistant professor of medicine at the Icahn School of Medicine at Mount Sinai and serves as the director of clinical biometrics in the Office of Interventional Cardiovascular Research and Clinical Trials in the Cardiovascular Institute here at Mount Sinai. Dr. Baber is a talented clinician, educator, and researcher with a primary interest in outcomes and treatment of high-risk patients, particularly those with underlying renal impairment, and has received fellowships to study platelet abnormalities in such patients. Please join me in welcoming Dr. Baber.
Thank you for that very nice introduction, Rachel, and I want to thank the Department of Medicine, the chief residents, Francine, Dr. Thomas, Dr. Murphy, for extending this invitation to me. It really is an honor and a privilege for me to have this opportunity to discuss this topic, the evolution of DAP, or dual antiplatelet therapy, from stars to twilight. This is a topic at one level is certainly of interest to me personally from both a clinical and a research standpoint, but broadly, the issues we're going to talk about with respect to antiplatelet therapy, risks, bleeding, how we balance those issues, these are not germane to just those of us in cardiology or more specifically in the cath lab, but actually are issues that are relatable to anyone who's going to take care of patients with underlying heart disease after an MI or stent implantation. So anesthesia, medical subspecialty, and so on and so forth. And over the last few years, there has really literally and figuratively been an explosion of research in this space, and it continues to evolve very, very rapidly. And I think at times this can get very confusing. Studies get published, signals might get mixed, how we disseminate, interpret these data can be somewhat confusing. And so to try to put some structure around this and some order around this apparent confusion, I've decided to just ask 4 very specific questions. And in the course of the next 35 minutes or so, we'll answer these questions at the end, answer them explicitly. The first question is, what's the minimum duration of DAP needed after we implant a stent in the contemporary era? And what we're really trying to ask here is, what is the sweet spot? What's the minimum amount of time I need to expose my patient to dual antiplatelet therapy to mitigate risk for early, which are largely stent-related thrombotic events? Is it 3 months, 6 months, 1 year? What's that minimum duration? The second question is related to the first, but is actually very distinct, and that is, once we get beyond that sweet spot, that minimum duration, is there a benefit to extending DAP beyond that time interval? And if indeed there is, who are those patients? Number 3, as a biological paradigm, we accept that as we inhibit platelets, we reduce thrombosis, yet we also pay a price with respect to bleeding. One way you can inform clinical decisions is if one of these events clearly outweighs the other in terms of prognostic impact. Well, do we have data that informs us and tells us whether or not bleeding complications confer a similar, less, or greater risk than thrombotic complications? And then finally, at the end, we'll touch on some novel strategies that we and others are deploying to simultaneously mitigate bleeding risk, yet not compromise antithrombotic efficacy. And one approach that I've taken to illustrate these concepts is to take a historical overview. Every time I teach residents or house staff, medical students, I try to emphasize that if we go back to the trials and the designs and try to understand what are the questions that are being asked, what was the fundamental hypothesis, I think that can really get burned into long-term memory. It lets you understand where we were, where we're going, and certainly where we are now. And so within that context, I've taken the last 20 years or so and categorized them in these 3 different bins. The first bin is the era of thrombosis, starting about 20 years ago with the STARS trial. This was a time when we were just beginning our experimentation with stents and trying to figure out what kind of combination of therapies we should administer to these patients. We discovered the drug-eluting stents at this time. We learned about this entity called stent thrombosis, began to characterize it. And we end this era with the first publication of the Academic Research Consortium, or ARC group, in 2007, a document that for the first time gave us standardized language to define and to quantify this issue of stent thrombosis, a document, by the way, that only focused on ischemic events. We then go into mid-2000s to a different kind of era, which I term bleeding awareness. This was a time interval when a lot of reports were coming in the literature telling us that bleeding is not just some nuisance collection of events that we need to consider, but actually has durable and real risks for mortality. And we end this era with another document by the Academic Research Consortium, but this one starts with the B, the Bleeding Academic Research Consortium, or BART, in 2011, that for the first time gave us, again, a standardized taxonomy to quantify, to measure, and to understand bleeding and its complications. And note that this document was only published 6 years ago, so we haven't had a lot of time with these very standardized definitions in cardiovascular clinical trials. And then finally, we are in the current era, which I'll call equipoise, an era that's really characterized by safer, newer generation stents, an era where we can finally start to experiment with strategies that were unthinkable 10 years ago, such as very short durations of DAP, such as withdrawing aspirin, and we'll touch on some of those. So let's just orient ourselves to the sort of the vascular space and anatomy that we're discussing here, and why we even administer any platelet inhibitors after we implant a stent. So in the top cartoon here, you see a metallic stent implanted in a coronary artery. These are the first bare metal stents that we started off with in the mid to late 1990s. And upon implantation of these stents, about 20 to 30% of patients would have the complication shown here, which is restenosis, or proliferation of smooth muscle cells. This complication, although common, was usually a morbid, not a mortal complication of stent implantation. And to mitigate this complication, we developed these new stents, the drug-eluting stents, wherein we coated these metallic scaffolds with an antiproliferative agent, which would simultaneously inhibit smooth muscle cell proliferation, so it took care of restenosis, but it also rendered the vessel more susceptible to activation of prothrombotic pathways and therefore stent thrombosis. A complication, while uncommon, is a mortal complication, usually presenting with myocardial infarction or even death. So let's go back to 1998, 20 years ago. Dr. Leon and colleagues published this seminal paper in the New England Journal of Medicine. 1,500 patients, a short-term outcome. Primary endpoint is largely a ischemic thrombotic endpoint. And the question that's being asked in this study is, what is the optimal combination of antiplatelets and anticoagulants to mitigate early thrombotic events after stent implantation? Notice that in the design of this study, all of the arms have aspirin. So this is a key point, foundational, and what was took to be sort of a priori is that you had to have aspirin as a minimum background therapy. So the question really was, what do you add to aspirin? Is it nothing? Is it an anticoagulant? Here they studied warfarin. Or is it another inhibitor of the platelets? Here you have an inhibitor of the platelet P2Y12 receptor, or ticlopidine. Well, the results were very clear. The best combination after implanting a stent in a human coronary artery was 2 inhibitors of platelets, one being aspirin, another being a P2Y12 receptor inhibitor. Other studies conducted around the same time showed exactly the same results. You see, over and over again, the combination of dual antiplatelet therapy clearly wins over other combinations of aspirin alone or aspirin plus an anticoagulant. So from these seminal studies in the late 1990s, we enter into the current era, the dogma of dual antiplatelet therapy. You put in a stent in a person, you've got to give aspirin, and then you've got to add another antiplatelet agent, not an anticoagulant. Other studies around this time also told us that these benefits were not just short-lived over 30 days, but in fact could be durable out to a year. If you recall, the CURE study was an ACS population, so we found benefits with dual antiplatelet therapy, and this is why we give dual antiplatelet therapy for a year after an ACS, by the way. And another study, the CREDO trial, in a more stable cohort, again showing us benefits out to a year. So most of these studies, again, were conducted with these bare metal stents. But in 2003 and 2004, we have the introduction of this really disruptive technology, these newer stents, the drug-coated stents that were supposed to take care of this issue of restenosis. The original stent platforms eluted paclitaxel or sirolimus. These are the same drugs we're still using in the current iteration of drug-eluting stents. The original trial showed marked reductions in restenosis and rates of revascularization, and the randomized trial suggested no safety signal with short up to 3 to 6 months of DAP duration. And just as an example, I have a table here showing 2 of the seminal trials that led to FDA regulatory approval for the original first-generation stents. Here you have the Sirius trial, here's the Taxus trial. Notice, in the trial protocols, you gave dual antiplatelet therapy for 3 to 6 months. Notice the endpoint of revascularization, the Achilles heel, the thing that we wanted to get rid of, is being reduced in absolute terms by 8 to 12%. These are large absolute reductions that we rarely ever see in clinical medicine, including cardiovascular trials. And notice the most concerning issue, this of stent thrombosis. In these early trials that led to the approval of these devices, you see no safety signal. Now, when these came out, these were really a very exciting time. We really thought we had an era where we had an implant we could put into patients percutaneously treat them, take care of their obstructive lesions, and they wouldn't have to undergo surgery. And the enthusiasm is illustrated in this study by Laura Mori and colleagues, showing us in short time as just 1 year how clinical practice changed. In early 2003, most stent implantation in Massachusetts was done with bare metal stents, over 80%. Within 18 months, over 90% of all stents being implanted across Massachusetts was done with drug-eluting stents, and these were patterns that were seen across the United States. But as the adage goes, if something's too good to be true, it probably is. And within a couple of short years, we start seeing reports in the lay literature and the academic literature telling us that there are some concerns about these first-generation stents. Here's a New York Times report from 2006, and here is the very first report in The Lancet highlighting 4 patients who had a presentation with myocardial infarction due to stent thrombosis a year after stent implant. Remember, the trials that led to approval said you only need to give DAP for 3 to 6 months. So these patients should no longer be at risk, yet they are now presenting with stent thrombosis and myocardial infarction, a major concern. And the fire only gets burned even hotter in 2006 at the European Society of Cardiology meeting, which has now been dubbed the Firestorm on DES. Investigators looked at real-world observational data, and the key findings were here out to beyond 1 year. Both the Taxus and the Cypher platforms were associated with higher rates of stent thrombosis compared to their bare metal counterparts, a major, major concern. We had implanted these in millions of people walking around who now have these stents, and now we may have a major public health issue on our hands because of this issue of late stent thrombosis. And there was a chilling effect on use and clinical practice around the world. All of a sudden, that uptick is no longer an uptick, but a rapid downtrend in use of drug-eluting stents everywhere. And other investigators start to try to understand this issue of stent thrombosis, try to characterize it. Who's getting stent thrombosis? What are the predictors of stent thrombosis? I like this paper by Yakovou and colleagues published in May 2005, which was really the first report, and it's really stood the test of time. Other studies since then have largely showed the same thing. And what Yakovou showed is that patients who get stent thrombosis have several parameters. One set of parameters relates to the patient. Does the patient have diabetes? Do they have renal failure? Other parameters have to do with the procedure itself. Are we treating a bifurcation lesion? How much stent are we implanting? And other parameters have to do sort of with a behavioral domain. Is the patient compliant? Premature antiplatelet therapy discontinuation has a high hazard for stent thrombosis. So all of a sudden we recognize that this issue of stent thrombosis is really a multidimensional construct. Risks for this construct are influenced by patient parameters, procedure parameters, and even sort of behavioral compliance parameters. So it's not so straightforward. And the Academic Research Consortium convenes and puts together the first paper, a major milestone in clinical trials for cardiovascular medicine. And here are the authors of that original seminal paper. And they put together standardized definitions. And this paper was really focused on stent thrombosis. This was an important event. We needed to understand it. We needed to quantify it. We didn't want to be imprecise in our estimations of this event. And this paper in it has no mention of bleeding, by the way. And the AHA and these other groups put together a science advisory that stresses the importance of 12 months of dual antiplatelet therapy after DES. So we are worried, we're concerned, and here we kind of close the era of thrombosis, and we shift from this into a different kind of time around in the mid-2000s with bleeding awareness. So while certain papers were telling us about stent thrombosis, here we have the first signal in 2006 from an ACS cohort by Eichelboom and colleagues telling us, hey guys, bleeding is also important. Now, some of these bleeding events are naturally intuitive. A life-threatening bleed, intracerebral hemorrhage, frank exsanguination, obviously those are going to be related to increased risk for death. No one is going to question that. But what about these less severe bleeds? The kind of bleed that gets you to the hospital, maybe gets you an endoscopy, you don't go to the ICU, you get a 1 or 2 unit blood transfusion and you go home. These are major bleeds, and these are also apparently associated with increased risk for mortality compared to patients who don't bleed. Dr. Moran and colleagues published this important observation from another ACS cohort from a randomized clinical trial in which the authors compared risks for mortality after an MI versus major bleed. And there are very important insights from this paper that I'd like to walk through. If you look at the mortality risk after myocardial infarction, look at this temporal relationship. Early after an MI, you have very high risk for mortality, but that risk attenuates very quickly. Within 30 days after an MI, your risk for mortality is no different than someone who didn't have an MI. And notice, however, the temporal pattern after a bleed. After you sustain a major bleed, you have a higher risk for mortality, and that risk is actually more durable over time. So for the first time in the literature, we are seeing evidence that these bleeds appear to be as risky as myocardial infarctions and maybe even more durable over time with respect to long-term mortality. Other investigators showed us it's not just the early bleeds that occur when a patient comes in for PCI or for an acute MI management. When we're loading patients with antithrombotics, heparin drips, 2B3 inhibitors, sure, those patients, if they bleed, are going to have high risk for mortality. But even beyond 30 days, we've discharged them. They're on dual antiplatelet therapy. They're no longer in the IV infusions. Patients who then bleed in the outpatient setting also have a comparable magnitude for mortality risk in that outpatient setting. And Dr. Rao and colleagues published this very important paper that also highlighted to us that the definitions of bleeding can strongly influence the estimates of mortality we get from bleeding events. At the time, the papers that were reporting on outcomes after bleeding were using protocol definitions or definitions used in those trials, the Gusto group, the TIMI group, and so on and so forth. But look at the different interpretation one can get. If you decide to use the Gusto classification, you will think a bleed has about a 6-fold higher risk for mortality. In contradistinction to TIMI major, about 1.5-fold higher. This obviously has major implications for how we're going to qualify and quantify risk for bleeding vis-a-vis thrombosis and future mortality. And because of this heterogeneity in definitions and the major impact this would have on our interpretation and what we would do as clinicians and investigators, the academic research consortium group got together. You will notice that many of the authors of this paper were on the first paper and got together and said we need a standardized definition to quantify bleeding, to measure bleeding, to speak intelligently, not only to one another, but to our patients, our clinicians, and to regulators. And along came the Bart criteria for bleeding, which has since been validated in multiple papers. So with those two kind of periods, we'll now go into the third era, the era that I think we're in right now, which we call the era of equipoise. And there are three key issues that allow us to sort of get into this era of equipoise. Perhaps the most fundamental and important is the iterative advancement in stent technology. The newer stents that we're using now have many differences compared to those early first-generation stents. They're thinner, they have different elution profiles of the drugs, different polymeric composition. And this histologic section, which has been shown in several studies, shows us exactly what's happening. So here you have cutouts from first-generation stent implantation a year out after implant. Remember, we believe that you only need 3 to 6 months of DAPT. But look what's happening here. These metallic struts are completely exposed to flowing blood. Obviously a nidus for thrombosis, a year out after stent implantation. Look at the right-hand panel, the newer generation stents, the one that we're using right now in this cath lab and other cath labs around the world. 3 to 6 months after stent implantation, you see that the stent struts are nicely embedded within a layer of endothelial cells and therefore should have, theoretically at least, much lower risk for thrombosis, and therefore these should be much safer. Well, do the clinical data support that? And indeed they do. Numerous analyses and meta-analyses have been done, and this is no longer theory. This is no longer kind of subject to guess. This is a fact that the newer generation stents that we use here labeled as COCREES, these are the most common platforms we use compared to pretty much anything else, are associated with much lower risk for stent thrombosis on the order of 50 to 60, even to 70% reductions in a relative scale. So we are now dealing with a technology that is truly disruptive, fundamentally safer for our patients when we implant these stents. And our European colleagues, who tend to be pretty quick with regulatory approval, gave approval for very short durations based on some of these early studies for the new platforms. And so that's sort of observation one for the era of equipoise, which is these safer stents. Another observation came forth to us by the Parish Registry, which was run by Dr. Moran and colleagues. And this was a registry, and the entire focus of this registry was to understand the relationship between DAPT cessation or antiplatelet therapy withdrawal and subsequent risk. Remember, this was one of the major issues we had in the Yakovu paper about 10 years ago. The insight from the Parish Registry was that the relationship between withdrawal of antiplatelet therapy and subsequent risk is completely influenced by the mode of withdrawal. For example, some patients in the Parish Registry underwent discontinuation, meaning their doctors decided that they no longer needed DAPT and they just took them off. Other patients were interrupters, meaning they needed some kind of a surgical intervention. They went off for about a week or two, and then they went right back on. And then you had disruptors. These were the non-compliant folks, or the patients who had a bleed and had to go off. The risk with stopping dual antiplatelet therapy was entirely confined to this group, the disruptors. So from this observation, we recognize that the relationship between stopping antiplatelet therapy and thrombotic risk is not just a biological cause and effect phenomenon. In fact, it's an epiphenomenon. It is fundamentally influenced by the underlying reasons that lead to withdrawal. Not only that, we found from the Parish Registry and others that while we're concerned about those patients who go off antiplatelet therapy, it turns out that the vast majority of events are not occurring on patients who stop dual antiplatelet therapy. They're actually occurring in patients who remain on dual antiplatelet therapy. 80% of stent thrombosis events, the most worrisome of all events, actually occur in patients who are on dual antiplatelet therapy. So if we're talking about public health, population level interventions, perhaps we need to focus a little bit more on the residual risk in patients who stay on dual antiplatelet therapy rather than the ones who are going off. That's sort of observation number 2. And observation number 3 came through with some analyses giving us a temporal interpretation with respect to risk after dual antiplatelet therapy withdrawal after PCI. This was the original paper by Aroldi and colleagues. It's been since shown by other investigators. In the red, you have the risk for thrombosis in patients who stopped their P2Y12 inhibitor or went off DAP. In the blue, you have the risk in patients who remained on DAP, and this is the time after PCI. Notice in the first 30 days after PCI, it makes sense. You've got about a 5-fold gradient in risk if you go off dual antiplatelet therapy. That's not terribly shocking. Notice what happens in up to 180 days, about a 2 to 3-fold increased risk, but look what happens after 6 months. After 6 months, there is no difference in risk for thrombosis between patients who stop versus those who do not stop dual antiplatelet therapy. So all of a sudden, we recognize there may be a temporal inflection point, maybe around 6 months, wherein there is no longer further risk after you stop dual antiplatelet therapy. And so we take all of these observations together, safer stents, we're getting to appreciate a little bit more how the nuanced relationship is between withdrawal of antiplatelet therapy and risk, this temporal dimension, and a whole host of investigators, largely in China and Europe, have the fortitude to conduct a whole host of trials where they're comparing all different durations. Here's a slide, over 30,000 randomized patients across 10 clinical trials, all different types of durations, 3 versus longer, 6 versus long, so on and so forth. The bottom line is all of these trials were testing the hypothesis of whether or not you could get away with a short versus a longer upfront duration of dual antiplatelet therapy, and all of these results continue to show the same exact finding, namely that an upfront strategy of just 3 to 6 months was just fine with respect to thrombotic endpoints. In other words, you didn't pay a penalty, you didn't cause MI by giving 3 to 6 month duration, and you actually reduce bleeding a little bit. So based on all of these studies, with these safer stent platforms, we begin to appreciate that there was no advantage to an upfront strategy of prolonging DAP beyond 6 months in reducing thrombotic risk in contemporary DES studies. And then came the DAP trial. This is a trial that has had such an impact on medicine, on guidelines, on practice, that we just need to walk through it a little bit and understand what this trial was doing compared to the other studies I just mentioned. The other studies I just mentioned asked the question of upfront, how long should I give? What's the minimum duration? In the DAP trial, the investigators took as sort of prima facie evidence that you had to start off with a 12-month duration. So in the DAP trial, all patients got 12 months of DAP. After you were done with that 12-month duration, and if you were doing fine, you got randomized to continuation of DAP versus just aspirin. So the fundamental question that was being asked by this trial, as opposed to the other trials, is whether or not there's a benefit in extending DAP beyond 1 year. The results of this trial were presented at the American Heart Association in 2014. Many of us, myself included, thought this would be a negative trial. We thought we were in this different era, safer stent platforms. How are you going to get any further reduction in thrombosis by extending DAP in event-free patients? Well, we were all proven very wrong. Indeed, you do. Here you see absolute reduction in stent thrombosis, 1%, 1.6% in MACE, 2% in myocardial infarction. Notice, however, despite these nice reductions in thrombotic endpoints, what's happening with death? Absolutely no reduction in all-cause death, in fact, a 0.5 increase, and in non-cardiac death, you have a doubling of the death rate. What about the penalty we pay in terms of bleeding? Again, the order of thrombotic risk reduction is about 1 to 2%. Bleeding is about the same. You pay a penalty, about 1% to about 2% as shown here. And so when these trial results came out, myself and I think many others were a little confused, trying to have a hard time reconciling these findings. First of all, if we're reducing MI and we're reducing stent thrombosis, and these are important events with important prognostic implications for mortality, how can you reduce MI and stent thrombosis and have no reduction in mortality? Are these later events somehow less impactful than the early events? What about this issue of non-fatal bleeding? Again, reduced thrombosis by 1%, increased bleeding by 1%. Is bleeding conferring such a mortality risk that's washing out any benefit? And finally, and perhaps most importantly, are these benefits of extending DAP uniform? When this trial was published, there were some in the academic community that made very bold statements. They said every single person, because of this trial, should get dual antiplatelet therapy after DES lifelong. Think about the implications of that statement to our surgical colleagues, to anesthesia, to all of us who practice cardiology, if you had to give lifelong dual antiplatelet therapy after every single DES. So an important insight from this trial is trying to figure out, trying to cherry pick who are the patients in whom the risk-benefit trade-off is optimal. Well, it turns out that late thrombotic events, in fact, probably are less important from a mortality perspective than early events. Here are data from one study, and others have shown this. Early stent thrombosis is about a 20% case fatality rate. Late stent thrombosis, 10%. So still an important event, but definitely as time goes on, it appears that these later events seem to be less impactful than the early events. What about bleeding? I mentioned the paper by Dr. Moran and colleagues, and we were able to do a similar work with a more contemporary cohort from the Parish Registry, asking the question in the contemporary cohort, what is the mortality risk after a bleed versus a thrombotic event? And what did we find? Well, in the top, you see the mortality hazard ratio after a coronary thrombotic event, 3.3. Here you have the mortality hazard ratio after an actionable bleed, 3.5. They're superimposable upon one another. So again, if you have an event of thrombosis that you're reducing by 1%, you have a bleed, you're increasing that by 1%, and both events have a comparable risk for mortality, it kind of makes sense that you're going to have a wash when it comes to a mortality signal in the overall trial. And finally, and perhaps most importantly, who are the patients in whom we can try to identify, in whom we can optimize the trade-off? Can we identify a subset of patients in whom we can gain a reduction in thrombosis without a prohibitive increased risk for bleeding? And one of the lessons, I think, from this trial also is that whenever a clinical trial is done, whatever treatment effect we get, whatever point estimate we get, we need to remember that's kind of a weighted average. Whenever you get an estimate from a trial, there are some patients who actually got no benefit, some patients who got harmed, some patients who benefited even more. So I think one of the lessons and nuances from these clinical trials is that we need to not use sort of a dogmatic binary approach and say this was the benefit and this is what I'm going to assume all patients will get, but try to understand the nuance in which patients can you get the optimal trade-off. And this is what Bobby Yeh and colleagues did from the DAP trial. They looked at their own trial and they tried to identify factors that would optimize this trade-off as illustrated here in this table. So you will notice that as the number of factors increases, you're more enriched with thrombotic risk factors, diabetes, MI, prior PCI, so on and so forth. You will notice as the score goes down, and in fact as you get older, you even get into a negative score, which would indicate more risk for bleeding. And this was the histogram of the DAP score in the DAP trial population. The patients who were 2 or greater, which is an important point, was about 45 to 50% of the entire trial cohort. And that's important because when the investigators analyzed their data according to their DAP score, they found a very interesting finding. Just focus your attention here on the left Kaplan-Meier curves. These are patients in whom the DAP score was low. These are the elderly patients who don't really have thrombotic risk factors. Look at what happens. They get no benefit by continuing dual antiplatelet therapy at all, and in fact, they pay a penalty with bleeding. So no benefit, risk-benefit trade-off is not ideal. In contradistinction, on the right, you have the patients where the DAP score is greater than or equal to 2. These are going to be your younger patients, the diabetics, the smokers who have multiple thrombotic risk factors. Look at what happens to them. Large reductions in MI or stent thrombosis, and you don't pay a penalty in bleeding. So this is one of the lessons and insights from this trial that has now been embedded in the 2016 DAP guideline update. As shown here, we now have in 2016 a class 1 indication, class 1, after implantation of a DES in the context of stable ischemic heart disease, class 1 for 6 months, 2B for 3 months if you have high bleeding risk, and 2B for beyond 6 months if your bleeding risk is low. So this notion of individualized care, assessing bleeding and thrombotic risk at different time intervals is fundamentally embedded within the new guidelines and illustrated here by this statement right from the guidelines encouraging the use of various algorithms such as the DAP score to help inform these very complex decisions. So what are some future perspectives? It's kind of where we are, where we've been, where are we going? Well, let's start off, as I mentioned, this with the STARS trial, the very first trial. I said that the foundation was aspirin. We started off with aspirin. Where does that come from? Well, it comes from studies such as this, the Anti-Thrombotic Trialist Collaboration, that tell us in certain patient populations, if you give aspirin compared to not giving anything, you reduce events. So we kind of grandfather that into the PCI era and just assume you got to start off with aspirin. But indeed, until very recently, we don't have experimental evidence, randomized trial evidence, telling us whether or not aspirin is indeed beneficial after stent implantation. And several investigators have now conducted studies. This is the first study, the WOST study, an important trial, which for the first time in a population of patients who underwent stent implantation compared the withdrawal of aspirin. Now, these were patients with atrial fibrillation or another reason to be on an oral anticoagulant, and they had two arms. One arm was triple therapy, so these are patients who got warfarin, they got aspirin, and they got a P2Y12 inhibitor, clopidogrel. This is your triple therapy arm, so PCI with AFib, and they compare that to double therapy, which was warfarin plus clopidogrel. So the experimental comparison here is aspirin versus no aspirin. And what did the results show? Large reductions in bleeding, and in fact, no penalty on thrombosis. This was the first demonstration ever to challenge the dogma, the paradigm of aspirin necessity after coronary stent implantation. Something that very few people, I think, would have the courage to try to do, but they did, and the results were very positive. And since then, we've had a host of other trials. Here's another one, Pioneer AF, which essentially tested different strategies, but in this one, they used a NOAC, or rivaroxaban, with clopidogrel versus other triple therapy arms, one with the vitamin K antagonist, one with the rivaroxaban. And again, what did the results show? In the top, you can see that the triple therapy arm with the vitamin K antagonist does the worst with respect to bleeding. The arms, including the Riva alone with clopidogrel, does superior with respect to bleeding, and we don't pay a penalty. So multiple studies, the WOST trial, Pioneer, and another trial that just came out at the European Society of Cardiology, have consistently now shown that at least in the context of atrial fibrillation patients who are undergoing stent implantation, there does not appear to be any benefit to giving aspirin. In fact, if you get rid of aspirin, you get an advantage. You reduce bleeding, and we don't seem to have any incremental thrombotic risk. So these are really practice-changing studies that will definitely have influenced guidelines and will continue to shape practice. What about if we get out of the AF space? Remember, these are all studies where we're still giving an anticoagulant plus at least clopidogrel. Well, can we even get away with aspirin and just give a single antiplatelet agent? And there are two trials that are testing this hypothesis. One is a global leaders trial, which is still ongoing. This is a proposition where you're taking about 16,000 patients treated with a certain stent platform. The experimental arm you will see here is getting TICA plus aspirin for a month, and then just monotherapy, just ticagrelor. So again, stent implantation, you're getting TICA plus aspirin for a month, and then you just go to ticagrelor alone for another 23 months. Just one agent after stent implantation. Unthinkable 4, 5, 6 years ago. And that's compared to standard DAP. And this study will probably have results later this year or early next year. And the Twilite Trial, which is our own study that we're running, Dr. Miranda is the global principal investigator of this study, and we at Mount Sinai are the sponsor. This is a trial where we are taking patients, high-risk patients, and we are administering ticagrelor plus aspirin for 3 months because we believe that's the sweet spot that you need, 3-month duration of DAP. And at that time point, we're going to randomize them in a double-blind, placebo-controlled fashion to TICA plus aspirin ongoing as a referent arm or ticagrelor plus placebo. And our primary endpoint for this trial is actually bleeding, 9,000 patient trial, global, with the primary, again, endpoint of bleeding. And we believe that the strategy of ticagrelor alone will be superior with respect to bleeding compared to TICA plus aspirin, and we will not pay a penalty on the thrombotic side. And as I mentioned, this is a trial where we have specifically designed the study to be enriched with those factors I've gone through in the Yakovu paper and the DAP score and so on and so forth, where patients will be enriched with both thrombotic and bleeding risk factors, and so hopefully will help us demonstrate the treatment effect that we are hypothesizing. And we're very happy. This is kind of our baby we've been working on for a few years. We started back in July of 2015 with just one patient, kind of sad, but you can see a nice exponential increase to where we are now. So we're well on our way, over 7,400 patients as of this morning, and we expect to be done by the end of this year. And so this will be hopefully be reported in the next 18 months or so. So I want to go back to my first slide, the specific questions I asked, and provide some explicit answers to those. The first question, what's that minimum duration in the contemporary DES era that we need to expose patients to dual antiplatelet therapy? Well, I think the evidence is clear and the guidelines support this. 3 to 6 months is going to be adequate in the vast majority of patients. Number 2, is there a benefit to extending DAP? Well, it turns out there is. If you look at scores such as the DAP score, about 40 to 50% of your patients will be candidates for this prolonged duration of dual antiplatelet therapy, and we can figure out who those are. We can use algorithms, patients with ACH, diabetes, other high-risk angiographic relation parameters. So we can use that information to inform clinical decisions about prolonging and continuing to expose patients to dual antiplatelet therapy. What about bleeding and thrombotic risk? Is there clear, unequivocal evidence that one is definitely more important than the other? Well, I would argue that the data continue to show that, in fact, bleeding has a similar risk as thrombosis does on mortality after PCI. And because of that, we need to think about both in concert and think about the optimal risk-benefit trade-off when we make these decisions. And then finally, what are some of the novel strategies and approaches that we're using to simultaneously lower risk for bleeding but not yet compromise antithrombotic efficacy? Well, certainly an upfront short duration is one, and this issue of aspirin withdrawal has become very popular, studied in multiple trials in the setting of atrial fibrillation when you at least have an anticoagulant as a background, but now we're even extending that to patients without an anticoagulant on background to high-risk patients undergoing PCI. And so as these trials come to fruition and are reported out, I think we'll have more options for our patients that might allow us to achieve both a bleeding reduction and maintain safety from an ischemic standpoint. So with that, I will conclude and certainly have to thank my mentors on this slide, Dr. Moran, with whom I work with directly in the clinical trials office, with whom we're running the Twilight study, Dr. Sharma, Dr. Kinney in the cath lab, and Dr. Fuster, who allowed me to come here and be a fellow and stay on, and Gennaro, who's one of the house staff here and who helped put the first version of these helped me put together these slides when they were first drafted. So thank you for your time, and I'll be here for any questions.
Thanks for taking on the apparently leading cause of death in the Western world, and it's so complex. 2 quick questions. One, there was once a lecture given here about Crohn's disease, and the shadow of Dr. Crohn was in the room because he had worked here at Sinai, but the lecturer somehow did not mention it. I would just like to say that 10 feet from you is Dr. Kohler, probably the world's leading creative person in the field of platelets and coronary occlusion. And I just wanted to do better than we did with Dr. Crohn. Secondly, earlier you showed a slide in which the pharmaceutical industry was probably surprised that one of the therapies you showed, or maybe it was a dual therapy, was producing more deaths than individual therapy. Is that right? You had an early slide like that?
The results of the DAP trial, is that what you're referring to? Yes, we had more deaths. Yeah, that's.
So I was going to say, can you imagine what goes on? Because I can imagine, I had been on a board of a publicly held company for health. Can you imagine what goes on when the data shows that the medication regime is producing more trouble than good? Are they going to tell us about it?
Yeah, well, so regulatory oversight and, there are many efforts now underway to make sure data are shared, that they're public, that they're much more transparent. I can tell you a lot of our studies now are hybrid combinations. The DAP trial, the one that I spent a lot of time on, was actually a study that was coordinated with the Food and Drug Administration and industry and academia. And yes, when these trials come out and they're negative or they're surprising, they have major implications, certainly for the company, for clinical practice. If you look at ticagrelor, for example, there's been a host of very negative trials. The trials with the first generation stents, actually Johnson & Johnson, that whole division that was producing those stents, stopped producing it. Abbott Vascular has just stopped producing one of their stents. So, companies invest hundreds and hundreds of millions of dollars. They have to do these trials. They're required by the Food and Drug Administration to report these results and have long-term surveillance. And so when the signals come out that are not favorable, those of us who work on these things report them, and then it gets out to the clinical community. Yeah, it has major implications. It can shut companies down, put people out of work, change practice. So.
Great, Dr. Kohler.
When you show us the bleeding association with mortality,
Yeah.
are those data already adjusted for the risk factors that are known to be associated both with bleeding and ischemic mortality?
No, thanks for that great question, Dr. Kohler. Yes, at least the data that I showed, the study that we did from the Parish Registry, they were all, in fact, they were simultaneously adjusted for bleeding and thrombosis. So we had simultaneous adjustment because it turns out, although when we predict patients who are going to bleed, when we predict patients who are going to have myocardial infarction, and although many risk factors overlap, in actuality, the true overlap is actually quite infrequent. So at least in the paper that I presented from the Parish Registry, not only did we adjust for all the risk factors, we even adjusted for bleeding and thrombosis simultaneously. So those are models that take into account pretty much everything that at least we measured in the study.
So why then does having a bleeding episode on day one confer a mortality that you're associating with bleeding 6 months or a year later?
Well,
if it's not associated with another bleed.
So I think I think the answer to that question, which many people have tried to answer, is largely related to, I think, identifying that bleeding is probably a marker of a unique patient population. Bleeding is a marker of people who are uniquely prone or susceptible, some other factor that portends a poor prognosis. And so it's very similar to what we found with withdrawal of antiplatelet therapy. It's not just a biological cause and effect. It's actually epiphenomenal as well. So
this gets back to my first question. So is it the bleeding that is the thing that's causing the mortality, is the way this is structured? Or is it just that bleeding happens to be a great biomarker of a high-risk population?
Well, I think to date, the weight of evidence would support the latter contention, that if you can prognosticate, if we can figure out who's going to bleed, that gives us very precise estimates for who's going to have subsequent death. But I do think there are emerging data that show that if we can lower bleeding, you can lower death. So radial intervention, for example, in acute MI lowers bleeding, you lower death. So how much of this association is true cause and effect, how much of it is associative, I think is still subject to question. But most of the data would support that, as you put, that it's probably a very unique marker of patients who are susceptible for death.
Dr. Kohler, there's another issue here with the bleeding patients that we should not forget, which will be very, very difficult to evaluate. It's the behavior of a physician taking care of that bleeding patient, where they stop statins and beta blockers on those patients for unknown reasons, maybe because they had a low blood pressure during the time of a bleed and now they're concerned, maybe they shouldn't be on a beta blocker. So life-saving therapies are also changed on those patients. We'll never know how to correct for those and to point out, is this a biomarker or is it just because bleeding is a bad event that then perpetuates other bad events for that poor patient?
Yeah, I think that's a really key point. But it's a long time after that.
Right, but I mean, those things take effect long effect.
How long does that affect the physician behavior?
Let's thank our speaker for a great review.